So we're just going to introduce Margaret O'Reilly, who's a nurse educator from the Metabolic program at one of the adult hospitals, or our biggest adult hospital out here in BC. And I have had the privilege of working with her, and she's been guiding me and the On Track work for, just 12 or 14 years. And then we got to reconnect again and look at tools and pathways and better preparation from the pediatric end. So really thrilled she could come on today and share with us her experiences from the adult perspective. So welcome, Margaret.
Thank you very much, Mary. It's a pleasure to be here and be able to hopefully have a discussion about the adult to pediatric handoff, or pediatric to adult handoff. As the back of this slide shows, it is a handing off of care, handing over of care. I work at the Adult Metabolic Diseases Clinic, and a little bit about us. Can everybody hear me okay?
Yeah, just fine.
Yes.
I'm talking to a telephone. A little bit about us. We opened in 1999, and we were the first freestanding clinic for adults in North America with metabolic diseases. All other ones were affiliated with hospitals. And we actually transitioned 124 patients from BC Children's Hospital. That was our biggest transition ever. There were people there that were 60 years old and still being seen at Children's Hospital. So we transitioned them over to our new clinic, and now we currently have about 550 patients, and that's 15 years. So it's grown quite a bit. We have a multidisciplinary team that's also grown from 4 people to over 10 of physicians, nurses, dietitians, a social worker, psychologist, and a genetic counselor. And recently we just launched our new website, so if you're interested in finding out more about us, that's our website address. Metabolic diseases, I can never resist a little opportunity to raise awareness about metabolic diseases. So I'll just tell you they're inborn errors of metabolism that are caused by defects in a specific gene, and the defects lead to interfering with the metabolism of fat, protein, carbohydrate, or energy. And examples are PKU, mitochondrial disease, and Fabry disease, among several others. We see patients with suspected or diagnosed inborn errors of metabolism who live in BC or Yukon and who are over the age of 18 years. Transition at the Adult Metabolic Diseases Clinic has evolved over the years, and we've tried several different things. The best thing that we've done, which has been since the beginning, is to do a twice yearly intake in October and April. We picked those times for various reasons. Those are times when there's not a lot of snow on the Coquihalla, which is a big highway from the interior of BC, for those of you not from BC, so that it made it easier for people to come. We didn't want to do it during March break or summer vacation. We wanted to make sure people would come. So those times generally work as best as they can for people. We dedicate 1 week to transition during these months, and at that time we don't see any other patients, with a few exceptions. But at that time we have the whole week dedicated to transitions. They have a longer appointment. They come, they have a little tour of our facility, maybe the lab, sometimes the hospital, sometimes their local hospital where they might be admitted if they have an acute condition where they're likely to be hospitalized at some point. They meet with the physician, the nurse, the social worker, and psychology every time, or every first transition meeting, whether they need social work or psychology involvement or not, just so that they meet all their team members, and the dietitian as needed if they have a diet-treated illness. And they get a package that for them and for their parents with the questionnaires on readiness for transition that Mary's developed, our contact information, frequently asked questions, and community resources. And we go through that at the appointment. So it's quite a comprehensive appointment for the first time. We try to make it really welcoming and fun so that they want to come back. what is working well for us is having transition coordinators at both the pediatric and adult sites. Currently, I don't think Kathy is on the call, but she's a nurse at BC Children's Hospital who's been amazing at getting transition going and making it happen really well for us, because that's what we really depend on. And she and I connect and are the representatives from each site. That's really helpful, having one point person that's coordinating the transitions. The second thing that works really well is having the twice yearly clinics dedicated to transition. It works well for a number of reasons. The first being that it makes it very clear who is responsible in the event of an emergency and who is responsible for formula funding. So we have metabolic formula funding that is quite expensive, and it depends on whose budget it comes out of, which if we haven't seen the patient, then we don't take care of them in an emergency and don't pay for the formula. Makes it a little clearer. It also decreases the chances of someone getting lost to follow-up, which can easily happen with this age group. They could just be discharged from children and go into the Netherlands. Exceptions, as I said before, there were some exceptions for people not being seen during transition week. We have a patient, for instance, whose father has Fabry disease, and she, during transition, or not during transition, she just came with her dad when he had his appointment. That makes sense. And wayward patients, you know, we just catch them when we can. We wouldn't make them come at a certain time if they were going to be very difficult to get in. Another thing that really helps and works well is the comprehensive transition summaries from the Pediatric Center with copies of relevant reports, letters, labs, pathology results, those kinds of things. Kathy gets that all together and then sends it to us so that we can all review it before the patient appointment, and that is super helpful. And the last thing that we've just started doing in the last year or so that's been really good is a planning meeting 6 months prior to the next transition clinic. So we have them in May and November. So right after the transition in April, we'd have a meeting, and right after the transition in October, with both the pediatric and adult teams. And that's a challenge to get that set up, but it's so helpful because we all connect. We hear all the details about the patients, the complex patients, and we make sure that everything gets done from the pediatric end before we accept care, and I'll talk about that a little bit more later. Obstacles to a successful transition, there's several, but I guess the three main ones are, the first one is getting pediatric specialists to refer patients to adult specialists. So, for instance, a pediatric cardiologist, say, to refer a patient to the adult clinic, because we get patients that come here and they're still being seen by that, and for us to organize that, that's a lot. Plus, it's a lot of change for them all at once. So recently, we had a pediatric specialist email the physician back at BC Children's Hospital who had requested a referral to adults, and he wrote back saying, I don't do referrals. That was it. No other explanation. So patient had to go back to the GP and get referred to the adult specialist, and just a lot of work. So that's kind of an obstacle. The second thing is getting the pediatric metabolic team to think of their patients as future adults, make plans and start discussions prior to transition. And I think this is just a big transition issue in general, but there are some things that need to be dealt with before they come to us so that we're not the bad guy, because, or the party pooper kind of thing. For an example, driving. You've got to think of pediatric patients as future drivers, and if they have an unstable condition, for instance, something with hypoglycemic episodes, they have to be thinking about how that's going to affect their driving. And career planning. We had a man who transitioned to our clinic, and his career goal was to become a pilot, and there was just no way that that was going to happen. But he had always gone along thinking that was possible and being told that that was a possibility. So we had to, rain on his parade, which is really hard to do. Yeah. Contraceptive issues. Sorry, this toolbar is over the slide, so I'm just going to try to find it here. Contraceptive issues. And IQ testing for funding, that's really key, and I'll talk about that in the next slide. From our end, the patient bookings sometimes can be complicated, and sometimes they don't get booked in properly, so that can be an obstacle to a successful transition. And as everywhere, sometimes we have no-shows and cancellations. Usually that there's something underneath that. We had one young man who just transitioned a few weeks ago. It was our 4th try with him, and after the 3rd no-show, I called his mom, and I wasn't able to get a hold of him, and she said that he was really reluctant to come and the reasons why. And so once we worked through that, it was no problem, and he came, and we made him feel really welcome, and I think it went quite well. So there's usually something to it. And challenges particular to adult care are primary care. That's a real challenge. The kind of understood a little more at a session that Mary had at BC Children's a few weeks ago, where they talked about the most responsible physician. I think what the idea I got was in the pediatric metabolic setting anyway, the pediatrician there is giving a lot of the primary care. A lot of times the kids are unstable, so the pediatrician wants to be the one in charge of the immunizations to see what their response would be, etc. With us, we can't offer primary care, and patients as adults are generally more stable. So it's confusing and hard for patients and families to go from transition from having primary care services offered in the pediatric setting to us not offering, and that's probably pretty typical. We offer a great service, so I can imagine most places would also not offer the primary care, involve that in. And the challenge with the primary care is that I'm sure it's nationwide. It's a challenge to get a good family doctor and to find a good family doctor, especially one who wants to take on a complex patient. So those are issues that I know that the Transition Committee is working on. The second issue is reproduction. For example, in our clinic, maternal PKU is a big challenge. There's young women with PKU have to be in perfect metabolic control, otherwise their babies will be very severely affected, microcephalic, mentally retarded, and basically erase the benefit of newborn screening. So they really need to be having a planned pregnancy, and if they're not, letting us know the minute they're pregnant so we can help them get into metabolic control. Another challenge particular to adult care is the normal stuff that would be taken care of in primary care setting. Hypertension, cancer, high cholesterol. I mean, those kinds of things make care more complex, and as people age, those things are more likely to happen. For example, we have a patient right now who has PKU, diabetes, and HIV, so that makes it a little bit more challenging. Another challenge in adult care, and something that's really difficult in transition, is the lack of funding and support for adults. So people feel like, especially parents of developmentally delayed young adults, when they come over to us, the bottom just falls out. It's probably hard for them not to confuse the two, like the transition to us and the bottom falling out. So, for example, Connect Place is a hospice program for young adults, kids, and that's not available to young adults, although we're working on that if they're, up until a certain age. PWD, persons with disability, is, like enhanced welfare basically, but it's a lot simpler for this application to be initiated in the pediatric setting, because then it's just a transfer of paperwork versus beginning a whole new set of work. And that paperwork can be so cumbersome for families, as you know. So making that, getting that going in the pediatric setting prior to transition. And IQ testing, as I touched on before, it's so important for that to be done before transition. If it's not done before the age of 18, they don't qualify for funding from CLBC, which is supporting community inclusion, like life skills, one-to-one workers, day programs, all that kind of stuff, group homes. So if that's not done, then it's a real big problem. So that's why the 6 months prior to transition planning meetings are so great, because we can say, oh, has this been done? Okay, it hasn't been done? Okay, great. Can you get it done? And then we'll take them. The last issue that is a challenge in adult care, and that is great to be done before they come over to us, is getting dental care done. Dental care, it's really hard to get appointments with adults to get an anesthetic. The OR time is a lot more limited in the adult setting. As I said, where we're heading right now, we've grown quite a bit in the last 15 years, and we're sort of like a tumbleweed. When people come to us, they don't go until, you know, they pass away or move, which is terrible to say, but and people are generally a lot more well, so they're living longer, which is fantastic. But where we're at right now is that we're actually looking at another kind of transition, which is transitioning stable people back to the community with support and education to their family care provider or their local specialist. But we will keep the newly transitioned patients for at least 2 years to get them established. And some people will keep. We can't keep everyone. We also have a lot of people that are referred to us for diagnosis, and then they can't get diagnosed. So it's just something we're working on. So as I say, a new kind of transition. Just wrapping up, I think if I had to say what the most important thing was, it would be like this slide. The background of this slide is passing the baton and teamwork, that it's the key to providing the best long-term outcomes for the patients who transition from pediatrics to adult care, and making sure that everything in between is taken care of, that every issue is addressed, and that they do have a soft place to land in the adult setting. I just wanted to end with special thanks to Kathy Withers, who isn't here today, but she's the head and heart of the transition team at the pediatric end of metabolic disease, and without her, we wouldn't have successful transitions at all. So thank you.
That's fantastic.
Thank you. I think we should open it up to people that have questions for you, Margaret.
Okay.
Margaret, can you tell me, this is Surjeet, what was the website? Sorry, I missed the website slide.
Oh, for our clinic?
Yes.
It's http://www.adultmetabolicdiseasesclinic.ca.
And where are you located?
We're at Vancouver General Hospital in the Diamond Healthcare Center, which is the ambulatory care center.
Okay.
Margaret, it's Elaine. First, what a fantastic, inspiring presentation. And so well done. Margaret, I'm just wondering, you may have been asked this question at least 100 times, specific funding for a recognized transition program, a recognized transition team. So is there specific funding for this work, or is it sort of part, it's a job that is part of a member of the metabolic disease team, or can you explain how that works?
Oh, yes. Well, no, it's just, there's no specific funding. It's just part of my job. And I was in charge of it when the clinic first opened. And then, you know, through the years, I've been here for 15 years. Through the years, you know, different maternity leaves and so forth, I've had other colleagues that have taken it on, but I've got it back. And so it's just part of my job description. And it's something that I'm really passionate and interested in as well.
Okay.
And I really enjoy working with Mary Peony, and she's very inspirational. So I think it's kind of an exciting thing to be part of and a really important piece of nursing to address.
Yeah, no, absolutely. And what you've pointed out here, which maybe hasn't come out, or at least to me not as strongly or as clearly, is the role of nursing, the opportunity for nursing in playing a tremendous leadership role in transitioning.
Mm-hmm.
Yeah. And from a hospital perspective, Margaret and Dr. Sandra Sears, who is her medical lead, and also she had practiced at Children's, so took that knowledge over to VGH, and Kathy together have provided us with so much frameworks for our whole On Track initiative. So we're basically building our complex tools, timelines, and right now we're working on our online toolkits for families. So they've created the framework for us. So this is that back and forth sharing. Yeah. And they've really, because they developed it over 12 years, are pretty clear on what works. And not only do they do all the nursing piece, they actually do the whole medical transfer piece as well.
Okay.
So it's significant. So that's that finding out what's working in clinical practice and then taking it to an organization level. And then now we'll be able to share that across all of our transition programs.
Hi, Margaret. This is Nancy from Halifax at the IWK, and I have a question. I'd like to learn a little bit more about your planning meetings between the peds and adult team. We have our first meeting with one of our clinics. It's actually, we're looking at rheumatology and nephrology specifically, but nephrology has their first meeting with their adult counterparts to kind of start that. So what was important in the early days when you first started to meet, and do you have any lessons that you could pass along for us?
So you mean the ones that we have 6 months prior to the upcoming transition?
Yes.
Yeah. So that is a relatively new thing, and what we realized, I guess the impetus for it was that people were coming when things hadn't been done. Mm-hmm. I'm not faulting the pediatric setting. It's just, you know, things just tick along, and then all of a sudden, boom, they're 18 and it's time to go. And so we decided, Kathy and I, the other nurse at Children's, decided that this would be a really good idea. And I think, too, she feels that probably this happens a lot, as well as sometimes the nurse might see the trees and not the forest and not the trees specifically, but the rest of the team wasn't kind of on board. So it was good to get everybody together. So that's a bit of the history. And then what she does the lion's share of the work, like getting all the information together. So she puts together a list of all the patients and their diagnoses and a little synopsis about them and which doctors are taking care of them, and then gets the room and all the people together and all that kind of stuff. Now I've forgotten the second part of your question.
Just any lessons learned along the way that...
Well, the biggest lesson is just working on that in-between piece and making sure that everything is covered in terms of all the issues specific to that patient. I mean, I think one thing with our patient population is it's not a cookie-cutter approach, because they all have something so different and their circumstances are so different, and I'm sure that is the case with a lot of patients. So looking at each individual patient and making sure that we don't just assume, I think that's the biggest lesson, that things have been addressed. and maybe talking about taking a different approach with the family if things have been difficult, communication's been difficult with the pediatric in the pediatric years, taking a new approach. That's by speaking to the team, then we can find out what the history has been and carry on, maybe in a different way based on their advice. I don't know if that's helpful or not.
No, it's absolutely helpful. Thank you very much.
Yeah, no problem.
Margaret, this is Surjeet from Fisher Health. Through NSS, we've run into this huge issues where any patients that are in at-home program, as soon as they turn 18, then there's nothing for them.
Mm-hmm.
Mm-hmm.
Frustrating. I had a very difficult, it wasn't a difficult family, but a father extremely upset because all the physio, it was a CT patient, and the physio and OT services, everything stopped as soon as
Mm-hmm.
son turned 18. And then there was a question about him, maybe his IQ was too high, but the fact that he was still developmentally delayed. He was still, I think, a student. I think he had just finished his 18th birthday. So it was really hard to deal with this family because there was nothing in place for them. No funding through CLBC. He wouldn't qualify for anything. So when you said about IQ testing to be done before they turn 18, but nothing available, and my heart just breaks for these families because how can we manage transitions for these patients? And home health program in Fisher Health, they won't take patients until they turn 19.
Yeah.
So there's a huge gap from 17 to 19 in Fisher Health. So your program, is it located under acute care program, or is it within community program?
It's ambulatory care, so it's under the acute care program. And yeah, I hear you about this services. Like the cupboard is bare for adults, and it's just appalling. But that's why this, getting the PWD application is going while they're in pediatric care setting is so important, and plus getting that IQ testing. We've had that too, where people's IQs are too high, and it's just like, oh my God. It's so hard for families, and it's just really a struggle.
And the equipment is not cheap. The power wheelchair that they needed, and the exercises that this kid needed, it was just terrible. And I felt so much at a loss as a nurse and a manager. I feel that there needs to be something in place for these special needs kids.
There definitely does. And we're lucky that we have a really good social worker who, can, I don't know how he does it, but sometimes can figure out ways of getting things done, but it is really challenging, and it's a big gap.
So is there a possibility for there to be an amendment or a updating of the provisions that have been set? And how long ago were these parameters set? For the kids who aren't well enough catered to? Like, is everything pending on an IQ status, for instance, which, hardly really embraces disability?
Exactly. Yeah, well, that's for the CLBC funding. But, yeah, I don't think in terms of the supports, financial supports for adults, I think that's what they get, kind of thing. And I think it's, I'm not sure, you can fight for it and try to get it reviewed and so forth, but I think that there's just, just so many dollars to go around. It just seems that there's a lot more allocated to children and to families when they're in the pediatric setting, so it just is really hard for them when they come here. And, the high school they often go to grade 13, or they, have an extra special year or something like that, just so that everything isn't changing at once?
Well, maybe this is one of the ambitions of transition, is for there to be its own guidelines, for there to be some of the meshing of the positive attributes of pediatric carried forward longer, and really state some strong parameters that are required for youth in transition as a legal status,
Yeah.
Yes, and we have often talked about that, and I know Mary addressed that at the last meeting we had, was that they're not sort of fully cooked by 18. It's this idea of transition being at 18. I mean, it's sort of right in the middle of their transitioning. I think, if these services extended to 25, or, even healthy, normal kids, including my nephew who's 27, he's still learning about being an adult. It's varied between, and I think these days kids are less mature than they were in the 50s or the 60s. Maybe not, but there's different. There's all sorts of different ways to look at it, but I think that the funding is a huge, huge barrier to a successful transition.
Yeah.
And to just having people like Surjit, you're saying, I mean, having someone in a good wheelchair and having the seating proper, that's going to prevent them from being in the hospital with bed sores, or, like, it's just forward thinking that is missing.
Yeah. And it's Mary here. I just want to say that's exactly why, looking at our clinical practice guidelines, that we are focusing on 12 to 24 in our age category, because they're transferring in the middle of their transition process. But just even today in the Sun was a whole page out here in BC, was the discrepancy between the services, the age break between 18 and 19 for CLBC funding. So across the country, every province has different pockets of how they do their funding. But overriding is the fact that a lot of these kids are new to the adult system. They didn't live to be part of the adult system. So the adult system's in this crazy catch-up mode, and then the best we can do with our guidelines is definitely to inform them. There's different parent groups, Movement Afoot for sure, from cerebral palsy, from our cancer survivorship groups. Across the country, people making it known that the services aren't in line with what these kids need. So if 98% of our kids are living well into adulthood, they're still not the numbers that are making a shift in the system. But they need to know they're coming, and they need to change the way we do business. Absolutely. But this is our health care. We're talking about transitioning them, to our adult clinics. But what comes up every time, and we had a big neuromuscular education day, and 21 kids and their families came throughout the province. The whole workshop focused on funding for to be able to live. These kids all wanted to go to university. So even though it was focused on that transition from pediatric to adult care, the conversation about funding to live became predominant. Yeah.
I think, Mary, it's Elaine to that point. Just last week at a board meeting, one of the conversations went to transitioning, and first of all, the diversity of age. When does pediatric end and adult life begin? The variation across the country goes from 14 to 19. So that alone is bizarre. And
I've never heard 14.
Yeah.
Yeah.
That's terrible.
And very much to your point a minute ago that, at 18, there's nothing magic about it. 17, 364 days, I'm a child or I'm a youth, and then the next day I'm an adult. No, you're not. No. Especially someone who has complex care needs, and that's when I just want to plant a seed before I forget that in addition to our challenge, and we will reach it, of making some recommendations around guidelines, standardizing them across the country, I really think we should also think about advocating and a strategy around that age definition. Because I think, if we talk about standardization of practice, so much of what Margaret has presented today is generalizable to every situation, any condition, any sort of, complex care situation. There isn't anything, I don't think, that, Margaret, you've shared with us that isn't generalizable. Your passion and focus is on metabolic disease, and that too crosses a huge spectrum. But my point being, I think maybe in parallel, we need to be thinking about bringing consistency and standard to that age definition, because it's all over the map.
Absolutely. And we even, and discrepancy between when you can use a pediatric emergency department, when they'll send you away, and when the adult center will accept you. So we have lots of issues that really run across all the provinces. And
just one more soapbox comment, and I will step back, I promise, is mental health in our emergency departments. That what you've just described in terms of when you can go to Peds ER, when you go to an adult, that's really had a huge impact to the current crisis of mental health in our emergency departments.
And at Royal Columbian Hospital, where I'm located at, it's a huge challenge. So what we've done for mental health pediatric patients is we bring them on our unit, even though it's a pediatric unit, and we're trying to set up or align services to meet the needs of these patients. My unit is in no way set up to care for mental health patients, but we're hoping with development projects, we're looking at providing a space for our pediatric patients who have mental health issues, and making sure that there's consistent services and resources available. But it's a huge challenge. Would rather have our mental health patients sit in on our pediatric inpatient unit than emerge. Emerge is not a place for a mental health patient.
And there's many who share that, Surjit, and I just want to confirm. So we're talking about Fraser Health at this point. When you talk about your site.
Yes, this is my experience.
And that's at Surrey Memorial.
I'm at Royal Columbian Hospital.
Okay, great. That's good information. Thank you.
And just to note too, there's a very large mental health collaborative looking at transition right now throughout the province, and they're piloting protocol and tools in our interior health. So it's definitely become a huge issue, and so they have picked up transition, and we've been partnering with them. So once all those reports come out, we'll share them with all of our CAFC partners.
That would be amazing. And just an FYI, we've got a concurrent symposium at this year's conference in Calgary on this very topic of the mental health crisis in the emergency departments.
I'll have some speakers for you if you're interested.
Okay.
So thank you, Margaret. Your talk, I know that Lisa will post it on the CAFC site,